Hi everybody, Neil Kravitz here. I hope you're enjoying these daily clinical pearls. I received two separate requests whether I could talk about surgical uprating of mandibular second molars, so I'd like to do that today. In my office, I frequently refer to oral surgeons to upright mesioangular second molars. Now this is a type of posterior crowding. It's very common in Asian Americans because of the larger size of the clinical crowns, and I think it happens not only because of an arch length insufficiency, but when the mandibular third molar buds are positioned above the second molar crowns. So if you look at a panoramic radiograph of a 9-year-old and you see the third molar buds higher, more superior than the second molar crowns, I think that causes the second molar to tip mesially during eruption. And if the tooth is about 45 degrees angulated, we will refer for the surgeon to surgically upright it. And the surgeon will simply take their elevator and they will simply luxate the tooth up. And that's it. That's simple. So we don't need to use any uprating springs. I used to bond a tube on the second molar or have the surgeon do it and immediately try to thread a wire through. I don't even do that anymore. Some surgeons like to secure the second molar with barricade or periodontal wound dressing, but other surgeons don't. Some surgeons like to take out the third molar simultaneously. Other surgeons don't. Some believe that it makes the uprating easier. Others believe that it stabilizes the second molar by keeping it in place. So it's all a personal preference of the surgeon. The technique they typically do is they'll put their finger on the molar while they upright the tooth. They will remove a little bit of buccal bone. So sometimes if the tooth is very horizontally positioned, they will upright it to the buccal and the tooth will actually be upright but out to the buccal. Now, those teeth are actually really hard to move lingually back into the arch because the enamel just does not resorb that dental alveolus. But this is a wonderful technique and it simplifies a lot of challenging orthodontic mechanics. Two things that I want to mention. Number one, make sure the patient doesn't need premolar extractions. Typically, if this is a posterior crowding case, instead of surgical uprating, you need to make sure this isn't an extraction case. Simple premolar extractions oftentimes make room for those second molars to erupt. And a lot of surgical uprating that I did early on in my career probably just needed premolar extractions if I look back at it. Number two, a lot of questions I get is when will the bone fill in after you upright the tooth? Because it's pretty scary. There's a huge bony defect. Well, it's a non-pathological defect. There's no bacteria in that area. That bone will refill. It typically takes about 6 months for it to fill up to its normal level. So give surgical uprating a shot. Just find one surgeon. If you have any questions, I have a few papers on the subject. I can always give you those papers. Thank you guys so much for subscribing to this page. Thank you for supporting the JCO.